It's Jonathan Munoz, and today we are going to do an HMP together. So this is a Cerner platform. I'm using it on my laptop, and let's do it. This is Cerner. You in residency will be asked to do an HMP. Even in your observerships, you will be asked to do an HMP. So this is the way I do it, and this is the way I expect my students to do it. If you do it the way I'm doing it, I will be impressed enough to say, okay, this guy knows what he's doing, and he is ready to do HMPs. He's ready to be useful to me as a helper, not just a follower that doesn't contribute. So let's start with the HMP. So you get this. This is the what you see when you open Cerner, and you go to the left, and there's this tab here, documentation. This is the way I do it. There's so many ways. The people from Cerner recommends to do it in a different way, but this is for me. This is the most direct way. I open the documentation tab, click on add, and I have my favorites. I will also look for this on the all forms and look for admission HMP note, but I already have it signaled as my favorite. So admission HMP, click OK, and you have the form open here. The form is just a skeleton of what the note should have. And what comes here, you shouldn't delete or adjust to what you think should be for it to look nice, to look clean. Why? Because each of these parts that the form has are parts that are needed in order for a physician to be able to document and bill and charge money for the mental work that you are doing. So when you submit your claim, you submit proof of the claim with this HMP note, and the people that revise your note says, okay, do you have the elements that make it a high complexity note? Like, do you have a chief complaint? Do you have a history of present illness? Do you have a review system? And if you don't have them, instead of paying you high, they will pay you medium. So for you as a resident or an observer, it doesn't matter because you don't get paid. But for an attending that supervises your work, it matters because your work is the way they get paid. So just keep that in mind. So for the Cerner note, date of service, chief complaint, this patient. So let me give you some information about this patient. This patient is 74, has a primary history of primary biliary cirrhosis on treatment with a recent scope, upper and lower. 5 years ago, that was negative for esophageal varices or ulcers or diverticular bleed. Comes today because she at home, she woke up at around 11 p.m. with rectal bleeding around her. So well, she woke up on a pool of blood, and it was painless. She didn't know what to do. She felt nauseous. Called her daughter and was brought into the hospital. And our initial blood levels showed that she had a hemoglobin of 7, which is low, and she was tachycardic. So that's all the history I have, and then the rest I will tell you as we keep going. So for the history of present illness, this is a 74-year-old female patient with past medical history of primary biliary cirrhosis with recent scopes by her outpatient gastroenterologist in Arcadia that were negative for esophageal varices or other GI pathologies as per patient report, who was brought into the ER today by paramedics with the chief complaint of sudden onset of sudden onset of what's going to call this rectal bleeding. So we have the chief complaint. This is the so for the HPI, for history of present illness, you need 5 elements to make it a billable note. So you need the chief complaint, and these elements come from the OPQRST mnemonic. So you need the onset, you need the problem, you need the quality. So progression, quality. The quality of this was painless, sign onset to and associated to nausea but not vomiting, only one episode, woke her from her sleep, patient reports not having other episodes since that one. So we have how many elements? We have 1 for the chief complaint, 2 for quality, which is painless, 3 for associated to nausea and vomiting, and progression, which means that has she had more, has she had less, has she hasn't had more. So the 4th one is the episode that she hasn't had more since arriving to the emergency department. And patient, and then after you add your 4 elements, the way you do it through your OPQRST, if it's pertinent for the OPQRST, because some complaints don't have OPQRST, right? Like weakness, there's no, you're gonna meet some elements but not all of them, and it's fine as long as you get 4, you're good. So this could be it for this, for the HPI. Now the other element that is important for to get a highly billable one is the social history. So you have to say if she smokes or drinks or does illegal drugs. Denies smoking, drinking, or using illegal drugs. Now Cerner doesn't have it. For Cerner, you have to enter it so it can show up or auto-populate. And I don't know how to use that. It's not very easy, but I like to just manually enter it here. So if you are an observer or a resident, just add it to your note so it's visible. Social history denies that. Family history is another part of the HMP that needs to be there. So if you don't know, the patient doesn't know. Patient does not know her maternal or paternal history. If you say non-contributory, it's not valid for billing. So review system, you have to say either, so there are 14 systems, and you could go through each of the systems like you should do as a resident or an observer, or you could say the shortcut, is 4 points ROS was done and it's negative except for what's mentioned in HPI. And why is 14 points? Why can it be 10, 9, 8, 3, 2? Why? Because for the insurance companies, there are 14 review systems. To make it highly billable, you have to do more than 10. So can I say 10? No, because if you say 10, then you have to list each of the 10s that you did. Otherwise, they won't know which ones you did. So it's for them to be valid, the shortcut to be valid, you have to say 14 were done. Then we go to the physical exam. And I have my own template. For the template, I'm going to use the full physical exam. You already got in this part, you already got the vital signs. Now you're gonna get to add your full physical exam. Now the patient is well developed, well nourished, the patient is alert and oriented. That is good if it's a stable patient, but remember, any admission patient, can the patient that you're going to admit to the hospital be a stable patient? Can she look fine? Then why are you going to admit her to the hospital? So it has to be something that conveys distress, something that conveys pain, suffering, need for admission. So for this patient, the constitutional will be distressed due to GI bleeding um, cachectic. She looks cachectic to me. And then the HENT is normal, the neck is normal, the respiratory is normal, cardiovascular was normal, but because she's bleeding, she's tachycardic, so I'm gonna ask tachycardic. And GI, all was normal there. Extremities, neurologic was normal, psychiatric normal, skin normal, and then we go to the, once you finish that, you also take a quick look on your blood work and you see a CBC that has a hemoglobin of 6.5 from 7.5 on admission. So initial was 7.5 and then 6.5, so 1 gram difference. And then we have MCV, which is low, and then we have sodium, which is low. So we have a couple of abnormalities here. Then the glucose is elevated, the CO2 is low. CO2 is a reflection of bicarbonate. And then what else? Alk phos is elevated from primary biliary cirrhosis. And all right, so with all this, we go to the assessment and plan, and the problem, we're going to list our list of problems, and the first one is going to be what's going to kill the patient. So suspected acute lower GI bleeding with acute blood loss anemia. So that's lengthy, but that is the way that nowadays we have to make diagnoses for them to be billable, for them to change severity, for them to adjust the mortality risk of a patient. If you just say rectal bleeding, that doesn't mean much. You have to say, why do you think this is rectal bleeding and what is this rectal bleeding causing? Okay, then we're gonna look at what are the other problems that this patient is having. So acute blood loss anemia, microcytic, you can add that. And then you also can add hyponatremia. Then primary biliary cirrhosis with thrombocytopenia, because you can see on the side that platelet count is 69. And then, did I mention on her physical exam that she was cachectic? Yes. So cachexia, and then cachexia, which also goes with malnutrition, right? Malnutrition is the whole evaluation. So malnutrition is a very popular diagnosis nowadays, and it changes the severity of the patient. So malnutrition, likely severe from chronic disease, primary biliary cirrhosis. And then let's look again through this. So white blood cell count is fine, everything else looks fine. All right, so we have all these problems. Let's see what she takes at home. She takes Creon, calcitriol, Lantus for diabetes. So then diabetes, you have to add diabetes. And Lasix for cirrhosis. Remeron. Remeron is an appetite stimulant. Sildenafil. Okay, so then we're gonna say that she has diabetes mellitus type 2 with hyperglycemia. And then we can say our plan. Why do I list the problems and why not to say the other way that people do it around is with the organ systems, problems by organ. So cardiovascular, tachycardia, NSTEMI, things like that. Why? Because this is easier for billing. This is easier for hospitalists. So I'm gonna say plan admit to inpatient telemetry, because you have to decide where to admit. Is this patient going to ICU, medical surgical for patients that are stable, telemetry for patients that are unstable or have a need for monitoring. So admit to inpatient telemetry will start Protonix IV infusion, will continue trending hemoglobin levels, transfuse If below 7, we'll order 1 unit of PRBC transfusion. And if you think this patient is bleeding, then you're going to say you either are consulting GI or you have the team that comes after you consulting GI. So for my use, I'm going to say morning team to consult GI for possible need for endoscopy. Patient at this time is reluctant to have endoscopic evaluations here, as she would prefer to have it done with her outpatient GI doctor. And then for diabetes, we're going to say glycemia protocol. For malnutrition, continue monitoring dietary intake. Then finalize with resume home meds once list is stable. And then go through your fixing. White is red, transfusion, and here endoscopic, glycemia, protonics is. So remember, try to make it as professional as possible, because these documents nowadays are visible by the patients and their families, and they print it, they take it to their doctors, they take it to their lawyers, and it's constantly evaluated. So this is it. That's my note for this GI patient, and hopefully it serves you to understand how we do admissions in the United States. This is the Cerner platform. It's different than the Epic platform. I'm doing the very basic work, and at the end I sign and submit. HMP, sign. Okay. Well, thank you guys.